This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Hi, let me share an unusual experience while performing a seemingly routine surgery. So this is a 65-year-old lady who is planned for a toric monofocal lens, and the rexus is done, hydrodissection is done, the nucleus mobility is confirmed, nucleus emulsification is done in a very controlled manner. So far so good, no issues at all. The cortex aspiration is begun, and again I find that everything seems to be alright. Time to implant the lens, and I'm performing the hydro implantation for this patient. And the lens is introduced into the eye in a very controlled manner. The implantation is quite uneventful, smooth, and as I'm trying to dial the lens in, I find something unusual. So as I'm trying to irrigate the OVD out of the eye and at the same time nudge the lens around or rotate it, I find multiple wavy things. Initially this is the OVD part of it, but I can see few fibers. So as I'm trying to maneuver the lens, I'm seeing few fibers which are moving around. So there's a lot of confusion at this stage. Is this cortex or is this something else? So the one on the left side seems to be cortex, but these faint fibers definitely don't look like a cortex. And at this stage I'm also noting that there is some amount of positive pressure, but something is not right. So I feel that there is a vitreous prolapse, more likely a transzonular vitreous prolapse. At this stage the lens is aligned along the intended axis. I'm trying to retract the iris and see that whether is there any posterior capsular tear, because these fibers are very much reminiscent of a vitreous prolapse. But when I retract the iris and see with my Synscue, there doesn't seem to be any peripheral posterior capsular tear. My irrigation is there in the left hand, and I've asked my assistant to load up a diluted Transzonular acetate, which is prepared by taking about 0.5 ml of triamcinolone acetate in a 2 ml syringe and mixing it with 2 ml of BSS. This gives us an ideal diluted solution, and as I inject it, we can clearly see that on my right hand side the triamcinolone acetate stained vitreous fibrils are seen. So let me zoom in and just show you that the vitreous prolapse is coming out from this area, and these fibers and couple of them are stained with triamcinolone acetate. So as we are observing these vitreous fibers here, let me just draw your attention to a small dot which is there behind the lens, and keep a watch on this, what happens when I perform the vitrectomy. Now time to perform anterior vitrectomy. And again, we have an option of performing the vitrectomy through the pars plana region as well, but in situations where we're doing a surgery in topical anesthesia, we want to perform a quick and efficient job. So I would prefer to go ahead and use the limbal root itself. So first, to begin with, I perform the cutting at the wound itself, and this just confirms whether the cutter is working well or not. And now the cutter is introduced, and then initially I just cut the vitreous which is visible on my right hand side, and then the cutting is continued by moving the probe around in the antechamber. So it looks like predominantly the prolapse has been from the right hand side, and at this stage I'm on the belief that the vitreous prolapse has been transzonularly. There is another differential diagnosis which you need to consider is, was there a peripheral posterior capsular tear? In the presence of a peripheral posterior capsular tear as well, the vitreous can prolapse from the periphery, and currently I'm ruling out peripheral PC tear simply because the lens is very stable as the vitrectomy is being performed. So if at all there is a posterior capsular tear, there is going to be some change in the morphology of the posterior capsule, and we could have seen the posterior capsular tear enlarge, or at least there should be some change which is not visible, and the lens is very much stable. So that is one point which is in favor of an transzonular vitreous prolapse rather than the vitreous prolapsing out from a peripheral posterior capsular tear. So as the vitrectomy is being performed, now I believe that most of the vitreous is cleared off. Let us look at also the dot which was there initially, just disappeared now. It came along with the vitrectomy. Chamber is free from vitreous now, but there is one single fiber which is still prolapsing. There's a mild peaking we can see. There's also a kink at the capsulotomy margin. So as I perform the vitrectomy, you can see that the peaking disappears and the pupil becomes round. But that one fiber is still elusive. You can see there is a small kink now, which is very obvious at the rhexis margin. So now I'm going with my Y hook and just trying to retract the pupil to visualize the peripheral part of the capsular bag. Just want to know whether is there a posterior capsular tear in the equatorial region. I'm just trying to retract the iris and see. Doesn't seem to be any. So during this maneuver, the vitreous fiber is clearly isolated and I need to deal with it. So again, go in with the cutter. The setting which I'm using now is the IA cut mode. The aspiration is 12 cc per minute. The vacuum is 250 and the cutting is 4000, and the cutter is just held there and you can see that the fibril is taken care of. So when the cutter moves, you can see there is a movement in the retrolenticular shadow. That's the vitreous cavity with the transzonular state, suggesting that there has been a connection between the vitreous cavity and the vitreous prolapse which is in the antechamber. So now I'm convinced that there is no more vitreous present in the antechamber. I'm going to use 0.1 ml of intracameral pilocarpine so that the pupil becomes round. And this is just to ascertain that I've not missed out on any single strand. So remember that we don't have to use a lot of pilocarpine, just 0.1 millimeter, because we know that these drugs can induce inflammation. So this is just used to confirm that we're not missed out on any individual vitreous fibril. The pupil is round, the stromal hydration is done. There's no manipulation required for the lens because the lens was already in the place and it was looking stable. So this is one such case where we had a transzonular vitreous prolapse and which can confuse us, and differentiating from a peripheral posterior capsular tear can be tricky. So these are the first day post-op pictures. The patient continues to do well. So that's it. Thank you for watching and hope you found this helpful.